Basics of Medical Biochemistry. First edition, 2022. Chapter 23. Biochemistry of Hormones, Part 1 of 4. By Professor Dr. Muhammad Jawad. MBBS, Dow, M. Philosophy, Ph.D., Dip M.E. 23.1 Introduction. Biochemistry of hormones or endocrinology is the study of hormones, the endocrine system and their role in the biological functions of the body. The nervous, endocrine, and immune systems are the major communication systems in the body. They integrate stimuli and responses to changes in the external and internal environment. All of them are crucial to coordinate functions of highly differentiated cells, tissues, and organs. The endocrine system is a set of ductless glands that secrete hormones into the bloodstream. It is regarded as the body's slow chemical communication system. The distance between the hormone producer cell and the hormone responder cell may be large, moderate, or small. Generally, its onset of action is slower, more prolonged and more diffuse than the nervous system. It is under the control of the nervous system and it is anatomically discontinuous. Principal functions of the endocrine system include maintenance of the internal environment in the body, maintaining the optimum biochemical environment, integration and regulation of growth and development, maintenance and instigation of sexual reproduction, including gametogenesis, coitus, fertilization, fetal growth and development and nourishment of the newborn. A hormone, Greek, exciting, setting in motion, is a chemical substance released from living cells, endocrine gland, that travels some distance to target tissues to have a biological control and regulatory effect on other cells of the body. It is secreted in very small amounts, transported usually in the blood. Its target cells have specific receptors and it regulates cell reactions by affecting gene expression, often gene transcription factors. Rates of secretion of hormones are extremely slow, which are controlled by negative feedback effects from the target organ to the secretory gland. Each hormone has its own onset and duration of action. Example: catecholamines are secreted in seconds and exhibit full actions in a few seconds to a minute. Aldosterone takes 1 hour to act, while thyroxine and growth hormones require months for full effect. Hormones do not start biochemical reactions but rather regulate them. They resemble enzymes in action but are not structurally proteins or RNAs. Most hormones circulate in the blood, coming into contact with essentially all cells. However, a given hormone usually affects only a limited number of cells, which are called target cells. A target cell responds to a hormone because it bears receptors for the hormone. Some of the hormones circulate only in designated areas, such as hormones of the hypothalamus, circulating in the hypothalamo-hypophyseal tract. Hormones affect behavior and behavior feeds back to affect hormones. Table 23.1 List of endocrine glands, their hormones and functions. S.No. Glands. Hormones. What do they regulate? Functions. 1. Hypothalamus. Release stimulatory factors and release inhibitory factors. Links nervous system to endocrine system. 2. Anterior pituitary. Adrenocorticotropic hormone. Melanocyte. Stimulating hormone. Growth hormone. Prolactin. Thyroid stimulating hormone, thyrotropin. Luteinizing hormone. Follicle stimulating hormone.
Beta-lipotrophin. Beta endorphins.
Master gland. That regulates all other endocrine glands and also control body growth. 3. Posterior pituitary. Antidiuretic hormone, ADH, / vasopressin. Oxytocin. Controls plasma osmolality, uterine contractions, and milk ejection in lactating women. 4. Thyroid. Thyroxine, T4. Triiodothyronine, T3. Calcitonin. Metabolism. Body heat and bone growth. 5. Parathyroid. Parathyroid hormone. Use of calcium and phosphorus. 6. Adrenal cortex. Aldosterone. Cortisol. Androgens. Retention of Na+ and loss of K+. Act as anti-inflammatory agents and regulate metabolism of carbohydrates, proteins, and fats. Regulate control over rapid growth spurts in pre-adolescence. 7. Adrenal medulla. Epinephrine. Norepinephrine. Both cause glycogenolysis in liver and skeletal muscles that leads to hyperglycemia. 8. Pancreas. Insulin. Glucagon. Somatostatin. Regulation of blood glucose. 9. Testes. Testosterone. Androgens. Dehydroepiandrosterone, DHEA, and androstenedione. Production of sperm. Development of male characteristics. 10. Ovaries. Estrogen. Progesterone. Peptide hormones. Activin, inhibin A. Inhibin B, relaxin. Follistatin and Müllerian inhibiting substance, Ms, or anti-Müllerian hormone. M. Production of eggs. Development of female characteristics. 11. Placenta. Estrogen. Progesterone. Human chorionic gonadotrophin. HCG. Human chorionic somatomammotropin, HCS, etc. Maintain pregnancy. 12. Thymus. Parts of the immune system. 13. Git. Gastrin. Secretin. Cholecystokinin, etc. Secretion of digestive juices and regulation of process of digestion. 14. Liver. Hepcidin. Iron level, decrease iron absorption in Git and its release from the body cells, activation of vitamin D. 15. Heart. Atrial natriuretic factor, ANF. Relaxation of smooth muscles, vasodilatation. Diuresis and natriuresis. 16. Kidney. Erythropoietin. Erythropoiesis, activation of vitamin D and conversion of progesterone to deoxycorticosterone. 17. Adipose tissue. Leptin. Regulation of body weight. 18. Skin. Cholecalciferol. Vitamin D3. Activation of vitamin D. 23.2 Classification of hormones. Hormones can be classified according to 1. Mode of action, 2. Chemical nature, and 3. Mechanism of action. 1. Classification according to the mode of action. Atypical endocrine. They are synthesized by endocrine glands and released directly into the blood to the target cell, e.g. glucagon and growth hormone. 2. Paracrine. They are synthesized near their target cells and transported by local diffusion, e.g. angiotensin and kinin. 3. Autocrine. They are produced and exert their effects on the same cells, example the action of some growth factors, prostaglandin and histamine. 2. Classification according to chemical nature. Steroid hormones. These are mainly derived from cholesterol, like sex steroids such as testosterone, adrenal steroids such as cortisol and vitamin D3 or cholecalciferol derived from 7-dehydrocholesterol. They are lipid-soluble, lipophilic, and diffuse rapidly through cell membranes. Other examples include hormones of ovaries, estrogens and progesterone, and hormones of the placenta such as HCG. 2. Protein/polypeptide hormones. These are released from endocrine organs such as the thyroid gland, parathyroid gland, adrenal medulla, pituitary gland, and pancreas. These are lipid insoluble. They are received by receptors external to the cell membrane. They may be large polypeptides like insulin and parathyroid hormones or small polypeptides like oxytocin and antidiuretic hormone, ADH. Some are glycoprotein hormones like follicle-stimulating hormone, FSH, thyroid-stimulating hormone, TSH, and luteinizing hormone, LH. 3. Amino acid derivative hormones. These hormones are derived from amino acids. Examples like thyroid hormones and catecholamines are derived from tyrosine. Similarly, melatonin is derived from tryptophan. 4. Icosinoids fatty acid derivatives hormones. Icosinoids are a large group of molecules derived from 20-carbon polyunsaturated fatty acids, i.e., arachidonic acid, which is the most abundant precursor for these hormones. It is stored in membrane lipids and released through the action of various lipases. The principal groups of hormones in this class are prostaglandins, prostacyclins, leukotrienes and thromboxanes. These hormones are rapidly inactivated by being metabolized and are typically active for only a few seconds. 3. Classification according to the mechanism of action. I. Hormones act through intracellular receptors, group I. These are lipophilic and need to transport protein to reach their target tissues. They have a long plasma half-life. Their action is mediated by forming a hormone receptor complex. Examples are thyroid and steroid hormones. 2. Hormones acting through second messengers, group 2. These hormones bind to cell membrane receptors. Their action is mediated by the second messenger. The second messenger may be cyclic adenosine monophosphate, CAMP, cyclic guanosine monophosphate, CGMP, calcium, phosphatidylinositol, and protein kinase cascade. The groups of these hormones are hydrophilic, do not need to transport protein to reach their target tissues. They have a short plasma half-life. These hormones are further divided into the following groups. A. Hormones that act by stimulating CAMP formation, TSH, MSH, CRH, ACTH, FSH, LH, HCG, calcitonin, glucagon, PTH, and adrenergic catecholamines. B. Hormones that act by inhibiting CAMP formation, somatostatin, angiotensin II, alpha-2 adrenergic catecholamines, etc. C. Hormones acting through CGMP, tripeptides such as ANP, BNP, CNP, and nitric oxide, NO. D. Hormones acting through inositol 1,4,5 triphosphate, IP3, and or calcium ions, alpha-1 adrenergic catecholamines, angiotensin II, ADH, gastrin, GnRH, oxytocin, platelet-derived growth factor, substance P, thyrotropin-releasing hormone, TRH. E. Hormones acting through protein kinase cascade, chorionic somatomamotropin, epidermal growth factor, erythropoietin, fibroblast growth factor, growth hormone, insulin, insulin-like growth factors I and II, nerve growth factor, platelet-derived growth factor, prolactin, etc. Table 23.2 General features of classes of hormones. Group I. Group 2. Chemical nature. Steroids, iodothyronines, calcitriol, retinoids, polypeptides, proteins, glycoproteins, catecholamines. Solubility: lipophilic, hydrophilic. Requirement of transport protein: yes, no. Plasma half-life: long, hours to days. Short, minutes. Location of receptor: intracellular. Plasma membrane. Type of mediator: receptor hormone complex. CAMP, CGMP, Ca2+. Metabolites of complex phosphoinositols. Kinase cascades. 23.3 Hormone receptors. A hormone usually affects only a limited number of cells, called target cells, which respond to a hormone because they bear receptors for the hormone. Each target cell has 2,000 to 100,000 receptors. Hormone receptors are cell-associated recognition molecules. They are protein in nature and reversibly bind to hormones. They have high specificity and sensitivity. The concentration of hormone in target tissues is usually higher than in circulation. Each receptor has at least two functional sites, I recognition site which binds specifically to the hormone and 2. Coupling or signaling site, it couples hormone binding to intracellular effect. Figure 23.1 Role of target cell receptors in hormonal action, source, slideplayer.com. There are three main classes of hormone receptors. 1. Receptors for protein/peptide hormones. These are membrane-associated and embedded in the plasma membrane at the surface of the cell. The interaction of hormones and receptors typically triggers a cascade of secondary effects within the cytoplasm of the cell. 2. Receptors for steroid hormones. These are usually found within the cytoplasm and referred to as intracellular receptors. 3. Receptors for thyroid hormones. These are found in the nucleus and are referred to as nuclear receptors. Activation of hormone receptors. Hormone receptors are dynamic in nature and their number responds to physiological and biochemical factors. Receptor production is either down or up-regulated. In the case of down-regulation, there is a decrease in the number of receptors in presence of an excess of the respective hormone. It is brought about either by endocytosis, also called internalization, or phosphorylation of the receptors. For example, the upregulation of the receptors occurs by the formation of more and more receptors in deficiency of the respective hormone. However, some exceptions are there. For example, excess of angiotensin II causes an increase in its receptors. When these receptors are blocked by a certain chemical agent, then these hormones are unable to do their action. In the case of end organ insensitivity, there is a congenital defect in receptors and respective hormones are no more effective. Table 23.3 Comparison between surface and intracellular receptors. Cell surface receptors. Plasma membrane. Intracellular receptors. Cytoplasm and/or nucleus. Stimulated by protein hormones, catecholamines and icosinoids. Stimulated by steroids and thyroid hormones. Generate second messengers, which alter the activity of other molecules, usually enzymes, within the cell. Alter transcriptional activity of responsive genes. 23.4 Mechanism of action of hormones. Activation of hormonal receptors plays a major role in hormonal action. Generally, the activation of hormonal receptors brings about three main changes: a change in membrane permeability, activation of an intracellular enzyme system and activation of genes. 1. Hormones acting through intracellular receptors. Thyroid and steroid hormones act through this mechanism. They diffuse freely into all cells. However, their target cells contain cytoplasmic, for steroid hormones, and nuclear proteins, for thyroid hormones, that serve as receptors for the respective hormone. The hormone binds to the receptor, forming a hormone receptor complex that is activated and undergoes a conformational change. This complex can bind DNA sequences called hormone response element, HRE, causing activation or inactivation of transcription of a specific gene. The HRE is situated adjacent to the 5' end of the respective gene. Another important site is found between the 3' end of HRE and the 5' end of the gene for the attachment of RNA polymerase II. This area of DNA is called the promoter element. The activation of the promoter element produces specific mRNA via coactivators. In the case of its inactivation, the process of transcription is inhibited via co-repressors. The hormone/receptor complex acts as a transcription factor, turning target genes on or off. Recently, some other accessory factors have been identified. These are found attached to HRE and hormone receptor complex to form a structure called hormone response unit, HRU. It regulates the process of transcription through several co-regulators which may either be activators or repressors. Figure 23.2 Mechanism of action of hormone acting through intracellular receptors. Steroid hormone, left, thyroid hormone, right. Two hormones acting through the second messenger, protein and peptide hormones like catecholamines as epinephrine and icosinoids such as prostaglandins, hydrophilic, find their receptors on the plasma membrane of target cells. The binding of a hormone to a receptor initiates a series of events that leads to the generation of so-called second messengers within the cell. The hormone is the first messenger. The second messengers then trigger a series of molecular interactions that alter the physiologic state of the cell. The second messenger may be cyclic adenosine monophosphate, CAMP, cyclic guanosine monophosphate, CGMP, calcium, phosphatidylinositol, and protein kinase cascade. Acyclic adenosine monophosphate, CAMP binding of a hormone to its cell membrane receptor activates a regulatory protein called G protein. The active G protein causes activation or inhibition of the adenylate cyclase, adenylyl cyclase, enzyme. It is a large protein integrated with the inner plasma membrane. Table 23.4 Types of hormones activating and inhibiting adenylate cyclase. Hormones activate adenylate cyclase. Hormones inhibit adenylate cyclase. FSH, LH, TSH, HCG. Glucagon. Beta-catecholamines. PTH and calcitonin. Somatostatin. Angiotensin II. Alpha-catecholamines. Stimulation or inhibition of adenylate cyclase depends on the type of activated G protein and type of hormones. If adenylate cyclase is activated, it catalyzes the formation of CAMP from ADP. The CAMP then mediates the effect of the hormone by one of the following mechanisms. Figure 23.3 Formation of cyclic adenosine monophosphate, CAMP, from ADP. A protein kinase, CAMP-dependent protein kinase is a tetramer formed of two regulatory subunits, 2R, and two catalytic subunits, 2C. R2C2 is an inactive kinase. On activation, 4 CAMPs bind to 2R leaving 2C free. Active protein kinase phosphorylates serine or threonine residues of a specific protein that mediate the hormone action. CAMP-dependent protein kinase is sometimes termed serine-threonine kinase. B gene expression, in which CAMP binds to a protein called CAMP response element binding, CREB, protein which binds to a specific HRE to affect gene expression. After mediating its effect, CAMP is hydrolyzed by phosphodiesterase, which is inhibited by methylxanthines like caffeine and theophylline found in tea and coffee respectively. Figure 23.4 Role of the second messenger in hormonal action. G protein. It is named G protein because it binds to guanosine, GDP or GTP. It acts as a relay station and consists of 3 polypeptide subunits, alpha, beta, and gamma. The alpha subunit is the catalytic subunit that binds to GDP under basal conditions. The binding of a hormone to its receptor activates the G protein. This activation results from the exchange of GDP into GTP on alpha subunit and dissociation of active alpha subunit from beta and gamma subunits. The active alpha subunit, alpha GTP, may activate or inhibit its substrate enzymes, adenylate cyclase or phospholipase C, depending on the type of alpha subunit and type of hormone. There are several types of G protein. GS stimulates adenylate cyclase. GI inhibits adenylate cyclase. GQ stimulates phospholipase C. Other types affect Ca2+ and K+ channels. After the alpha subunit exerts its action, the GT-PASE activity of the alpha subunit hydrolyzes GTP into GDP plus pi, leading to its inactivation and reassociation with beta and gamma subunits, and remains inactive until reactivated again. Figure 23.5 Role of G protein in hormonal action. 2-cyclic guanosine monophosphate, CGMP. It is the second messenger for a group of hormones called atrioptins. Example: atrial natriuretic factor, ANF. These atrioptins are produced in cardiac atrial tissues. They cause relaxation of smooth muscles, vasodilatation, excess of water in urine, diuresis, and increased secretion of sodium, natriuresis. ANF binds to its receptor forming a hormone receptor complex. This complex activates membrane-bound guanylate cyclase. Active guanylate cyclase catalyzes the formation of cGMP from GTP. cGMP activates cGMP-dependent protein kinase, which in turn phosphorylates several proteins to mediate the effect of ANF. After mediating its effect, cGMP is hydrolyzed by phosphodiesterase into its inactive form. 3. Calcium or phospholipids. Hormone receptor complex activates a specific type of G protein, GQ. The active G protein activates the enzyme phospholipase C, PLC. The active PLC hydrolyzes phospholipids from the cell membrane such as phosphatidylinositol 4,5-bisphosphate, PIP2, to diacylglycerol, DAG, and inositol 1,4,5-trisphosphate, IP3. DAG activates protein kinase C, which phosphorylates specific enzymes that mediate the effect of the hormone. IP3 stimulates Ca2+ influx, entry, and releases Ca2+ from mitochondria or endoplasmic reticulum. Ca2+ also activates calmodulin protein. Activated calmodulin stimulates specific protein kinases which phosphorylate many proteins, mediating hormonal action. Hormones utilized in this system are epinephrine, norepinephrine, angiotensin II, antidiuretic hormone, gonadotropin-releasing hormone, thyroid-releasing hormone, etc. Figure 23.6 membrane phospholipid breakdown product as the second messenger, the phosphatidylinositol system. 4. Protein kinase cascade. Some hormones act on receptors with an intrinsic tyrosine kinase activity such as insulin, which has a protein kinase activity in its cytoplasmic domain. The binding of insulin to its receptor causes activation of tyrosine kinase, which autophosphorylates its receptor. The phosphorylated receptor phosphorylates a group of molecules called insulin receptor substrate, IRS, on tyrosine residue, leading to a cascade of physiological events in the cell. These reactions involved a series of alternating phosphorylation and dephosphorylation by protein kinases and phosphatases respectively. The binding of some other hormones like growth hormone, prolactin, and cytokines to their receptors causes activation of the associated cytoplasmic tyrosine kinases called Janus kinases, JAK, which phosphorylate the receptor on a tyrosine residue. This phosphorylation activates a cytosolic protein called a signal transducer and activator of transcription, STAT. The phosphorylated STAT is translocated to the nucleus to bind specific DNA elements and then activate transcription. It has been noted that certain hormones have different modes of action. For example, adrenaline stimulates the formation of CAMP in liver cells via beta-adrenergic receptors, but in the case of alpha-2 adrenergic receptors, it acts by decreasing the formation of CAMP. This different behavior of hormone depends upon the type of receptor, type of target tissue, and set of enzymes responsible for phosphorylation. 23.5 Some important features of hormones. 1. Synthesis of hormones. Generally, hormones are synthesized in their respective endocrine glands. All protein hormones are synthesized in the granular endoplasmic reticulum. Amino acid derivatives hormones are formed by enzymatic action in the cytoplasm of glandular cells. Adrenal medullary hormones are secreted like peptide hormones. All steroid hormones are derived from cholesterol. Enzymes that produce steroid hormones from cholesterol are located in mitochondria and smooth endoplasmic reticulum. Prostaglandins, prostacyclins, leukotrienes, and thromboxanes are derived from 20-carbon polyunsaturated fatty acids, i.e., arachidonic acid, which is found in membrane lipids and released by the action of various lipases. 2. Half-life of hormones. A biological half-life is a time taken by a substance such as a hormone or a drug to lose half of its pharmacologic or physiologic activity. Hormones have a wide range of half-lives. Some hormones have very short half-lives but have them extended by being chaperoned by binding proteins. Other hormones do not need a binding protein and can survive in the bloodstream for hours. 3. Forms of hormones. Many hormones are secreted initially in an inactive form as preprohormone or prohormone. During activation, they lose some of their structural fragment or undergo some other chemical changes. For example, insulin is secreted first as preproinsulin, which is converted to proinsulin after losing about 2,500 amino acids. Proinsulin is then cleaved to form the active hormone and the connecting or peptide. Similarly, parathyroid hormone, PTH, is secreted as pre-pro-PTH having 115 amino acids, is first converted to pro-PTH, 90 amino acids, and then to PTH, 84 amino acids. For storage of hormones, generally, the storage of hormones is limited. Steroid hormones are freely permeable to membranes, lipid-soluble, so they are not stored in cells and are immediately released. However, the thyroid gland stores a significant amount of thyroid hormones. On stimulation, abrupt release of hormone occurs, followed by slow and sustained release till the stimulus persists. 5. Release of hormones. It can be of the following types. Humoral, fluid, stimuli, for example, the blood level of Ca2+ directly controls parathyroid hormone and calcitonin release. Similarly, increase in blood glucose level causes the release of insulin from the pancreas. 2. Hormonal stimuli, for example, thyroid stimulating hormone triggers thyroid hormone release. 3. Neural stimuli, for example, nervous impulse causes the release of epinephrine from the adrenal gland. 6. Regulation of secretion of hormones. Hormones are released in response to an alteration in the cellular environment. Cortisol secretion occurs with a periodicity and is regulated by the diurnal rhythm of ACTH release. Hormones are regulated by negative and positive feedback mechanisms. For example, the dominant regulator of PTH is plasma Ca2+. Secretion of PTH is inversely related to plasma Ca2+ level. Maximum secretion of PTH occurs at plasma Ca2+ below 3.5 mg/dl. At Ca2+ above 5.5 mg/dl, PTH secretion is maximally inhibited. An example of a positive feedback mechanism can be seen in the case of estrogen. The pulsatile increase in estrogen secretion from the ovarian follicle takes place during its development. This raised level of estrogen causes an increased release of gonadotropin-releasing hormone, which then causes increased secretion of LH to perform ovulation. Figure 23.7 Regulation of secretion of ovarian hormones by the positive and negative feedback mechanism. 7. Onset of action. The onset of hormone action may be immediate, delayed, or both. For example, the immediate effect of ACTH is the sudden release of cortisol, while its delayed effects are hypertrophy and hyperplasia of the adrenal cortex. 8. Extent of action. It may be local or generalized. Oxytocin has a very specific and local action on uterine contraction. Growth hormone and thyroid hormone affect almost all systems of the body. 9. Permissive actions of hormones. Permissiveness is a biochemical phenomenon in which the presence of one hormone is necessary for the action of another hormone. It stimulates the formation of receptors of that hormone. For example, glucagon can do gluconeogenesis in the liver only in the presence of cortisol. Similarly, PTH requires the active form of vitamin D for its action on bones. 10. Hormonal rhythms. Hormonal rhythms and pulsatility are the adaptations of hormonal secretions to environmental changes, such as seasons of the year, the daily light-dark cycle, sleep, meals and stress. Circadian/diurnal rhythms. It is the 24-hour cycle that includes physiological and behavioral rhythms like sleeping. It is well demonstrated by ACTH and cortisol, whose level is highest in the early morning and lowest at midnight. Melatonin is the hormone responsible for regulating the sleep-wake cycle in a human being. This hormone is secreted by the pineal gland. Although the main circadian hormone is melatonin, other hormones like leptin, cortisol, growth hormone, ghrelin, etc., are also important for the rhythm of life. 2. Ultradian rhythms. It is the biological rhythms with a shorter period and higher frequency than circadian rhythms. An example is positive feedback action seen in the ovulation process. 3. Infradian rhythms. The biological rhythm that lasts more than 24 hours, such as a menstrual cycle. 11. Abnormal hormones. sometimes abnormal hormones are secreted which are unable to do their normal functions. Immature and incompletely formed hormones are examples of abnormal hormones. Immunoglobulins and antibodies may also produce that bind to hormone receptors and alter their actions. 12. Hormone resistance. It is the condition in which hormones are unable to do their actions due to a variety of reasons. Important causes of hormone resistance are defects in receptors, defects in hormone action, presence of antibodies against hormone or hormone receptors, and absent or defected target cells. 13. Ectopic production of hormones. These are the hormones produced by tumors derived from tissues that are not normally engaged in the production of that hormone. Ectopic hormone production is generally considered inappropriate and detrimental as these hormones can deregulate respective metabolic functions. 14. Hormonal assay. An immunoassay is a test that uses antibody and antigen complexes, immunocomplex, as a means of generating a measurable result. Immunoassays utilize antibodies to detect analytes of interest. The analytes being measured may be those that are naturally present in the body, such as hormones, those that the body produces but are not typically present, such as a cancer antigen, or those that do not naturally occur in the body, such as an abused drug. Important types of immunoassays available are radioimmunoassay, fluorescence immunoassay, enzyme-linked immunosorbent assay, ELISA, etc. By these methods, a very small amount of hormone in a sample can be measured. 15. Hormones as drugs. Hormones are widely used as therapeutic agents to treat a variety of medical disorders. For example, catecholamines are frequently used in the treatment of cardiovascular, psychiatric, neurological, and other clinical disorders. Dopamine is used in the treatment of traumatic and cardiogenic shock. On the basis of anti-inflammatory properties, glucocorticoids are widely used to reduce the inflammatory destruction of rheumatoid arthritis and other autoimmune diseases, to prevent the rejection of transplanted organs and to control asthma. 23.6 Hypothalamus and pituitary gland. It is a small but complex appendage found at the base of the brain, in the sella turcica, which is the most median depression in the medial cranial fossa of the sphenoid bone. The pituitary lies just inferior to the hypothalamus. Hypothalamus and pituitary are connected by stalk containing nerve fibers and blood vessels. The pituitary gland or hypophysis cerebri weighs about 600 mg and is composed of two lobes, anterior pituitary and posterior pituitary. Figure 23.8 Hypothalamus and pituitary gland. Source: my.clevelandclinic.org. There is a clear contrast between nervous system structures and endocrine structures. But certain nervous system cells act as endocrine cells, and certain endocrine tissues are derived from neural ectoderm. Nerve cells that produce hormones and secrete them into the bloodstream are called neurosecretory cells. In humans, neurosecretory cells are found in the hypothalamus. Hypothalamic pituitary axis is composed of the hypothalamus, pituitary gland, i.e., anterior pituitary, adenohypophysis, posterior pituitary, neurohypophysis, and pars intermedia. 23.6.1 Hypothalamus. It is a small structure at the base of the brain. It regulates many body functions, including appetite, thirst, and body temperature. The hypothalamus directly controls the secretions of the many endocrine glands like pituitary, thyroid, mammary, adrenal, and gonads. It also regulates the functions of these endocrine glands via hypothalamic releasing factors, which may be release-stimulating factors or release-inhibitory factors. Following are the important hypothalamic hormones or factors. Corticotropin, ACTH, releasing hormone or factor, CRH or CRF. Thyrotropin, TSH, releasing hormone or factor, TRH or TRF. Follicle-stimulating hormone, FSH, releasing hormone or factor, FSHRH or FSHRF. Luteinizing hormone, LH, releasing hormone or factor, LHRH or LHRF. Growth hormone, GH, releasing hormone or factor, GHRH or GHRF. Growth hormone, GH, release inhibiting hormone or factor, GHRIH or GHRIF. Prolactin, PL, releasing hormone or factor, PLRH or PLRF. Prolactin, PL, release-inhibiting hormone or factor, PLRIH or PLRIF. Melanocyte-stimulating hormone, MSH, releasing hormone or factor, MSHRH or MSHRF. Melanocyte-stimulating hormone, MSH, release-inhibiting hormone or factor, MSHRIH or MSHRIF. Figure 23.93 Methods of hypothalamic control over the endocrine system, source, slideplayer.com. Note, FSHRH and LHRH are the types of gonadotrophin-releasing hormone, GnRH. GnRH promotes the secretion of FSH and LH. GnRH is the key regulator of the reproductive axis. Its pulsatile secretion determines the pattern of secretion of FSH and LH, which then regulate both the endocrine function and gamete maturation in the gonads. Hypothalamic hypophyseal dysfunctions. 2 disorders have been noted with abnormality in hypothalamus. Eifrelichia syndrome, adiposogenital dystrophy. It is a rare childhood metabolic disorder characterized by obesity, growth retardation, and retarded development of the genital organs. It is usually associated with tumors of the hypothalamus, causing increased appetite and depressed secretion of gonadotropin. There is damage to the appetite-regulating center, APSTAT, of the hypothalamus. 2. Lawrence-Moon-Bardet-Biedl syndrome. It is a very rare genetic disorder that causes deterioration in vision, extra fingers or toes, polydactyly, obesity in the stomach and abdomen, mental retardation, and learning difficulties. 23.7 Anterior pituitary gland or adenohypophysis. It is subdivided into the pars diastalis, pars intermedia, and pars tuberalis. It is one of the highly vascular organs having the highest blood flow of 0.8 ml/gram/minute. It has been known as the master gland, but now this status is truer for the hypothalamus. 3.7.1 Hormones of the anterior pituitary gland. Histologically, anterior pituitary gland is composed of chromophobes and chromophil cells. The chromophobes have no granules and do not secrete any hormone with the doubtful exception of ACTH. The chromophil cells are highly granular and actively secrete hormones. These are divided into 2 groups, acidophil or alpha cells and basophil or beta cells. The acidophil cells are further divided into 2 types, i.e., somatotropic cells which secrete growth hormone and mammotropic cells which secrete prolactin. The basophil cells are of 3 types: A. Gonadotrophic cells, secrete FSH and LH, B. Thyrotropic cells, secrete TSH, and C. Corticotrophic cells, secrete ACTH. The main hormone of the anterior pituitary is the growth hormone. Following are the other hormones secreted by the anterior pituitary. 1. Thyroid stimulating hormone, TSH, or thyrotropin. It triggers the release of thyroid hormones. Thyrotropin releasing hormone, TRH, promotes the release of TSH. It is essential for the activity of the thyroid gland. It increases the number of thyroid cells as well as their secretory activity. It enhances the trapping of iodide by the thyroid, resulting in increased synthesis of thyroid hormones. 2. Adrenocorticotropic hormone, ACTH. It stimulates the growth of the adrenal cortex and stimulates it to secrete glucocorticoids. Corticotropin releasing hormone, CRH, from the hypothalamus, causes the secretion of ACTH. Its half-life is only 10 minutes. At rest, the rate of secretion of CRH is low and ACTH is produced in a very small amount. But its secretion is increased significantly in various stressful conditions like pain, hypoglycemia, hypovolemia, hypotension, surgery, infections, exposure to severe cold or heat, and emotional excitement. The secretion of ACTH is controlled by plasma cortisol level through a negative feedback mechanism, i.e., high plasma cortisol level decreases, while low plasma cortisol level increases the secretion of ACTH. The stimulatory effects of ACTH are prominent in the zona fasciculate and zona reticularis of the adrenal cortex. These areas of the adrenal cortex are rich in receptors for ACTH called melanocortin 2 receptor. ACTH brings about its effect by increasing the formation of CAMP, which ultimately stimulates the enzymes catalyzing the synthesis of glucocorticoids mainly. 3. Follicle-stimulating hormone, FSH. It initiates the growth of ovarian follicles each month in the ovary and stimulates one or more follicles to develop to the stage of maturity and ovulation. FSH also stimulates estrogen secretion by developing follicles and stimulates sperm production in the male. FSH stimulates testicular growth and enhances the production of an androgen-binding protein by the Sertoli cells, which are a component of the testicular tubule necessary for sustaining the maturing sperm. 4. Luteinizing hormone, LH in males. LH is also called interstitial cell stimulating hormone, ICSH. It stimulates testosterone production from the interstitial cells of the testes, Leydig cells. In females, it acts with FSH to stimulate estrogen secretion and follicle growth to maturity, causes ovulation, causes luteinization of the ruptured follicle and stimulates progesterone secretion by the corpus luteum. Gonadotropin-releasing hormone, GnRH, promotes the secretion of FSH and LH. When a female enters menopause and her ovaries stop working, FSH levels will rise. Low levels of FSH and LH are consistent with secondary ovarian failure due to a pituitary disorder or hypothalamic problem. Low FSH serum levels have been associated with an increased risk of ovarian cancer. 5. Prolactin, PL, or lactogenic hormone. It stimulates breast development during pregnancy and secretion of milk after the delivery of the baby. The secretion of prolactin is under the control of the hypothalamus through its prolactin release inhibiting hormone, which is chemically dopamine. The action of dopamine is brought about by its interaction with adenylyl cyclase-linked dopamine 2, D2, receptors on lactotropes. In addition to tonic inhibition by dopamine, prolactin secretion is positively regulated by several hormones, including thyroid-releasing hormone, gonadotropin-releasing hormone and vasoactive intestinal polypeptide. Stimulation of the nipples and mammary gland, as occurs during nursing, leads to prolactin release. It also influences behavior and regulates the immune system of the body. Hyperprolactinemia is a condition of raised prolactin in the blood of women who are not pregnant and in men. Some women have high prolactin levels without any symptoms. In men, high prolactin levels can cause galactorrhea, impotence, inability to have an erection during sex, reduced desire for sex and infertility. Hypoprolactinemia is the condition of low secretion of prolactin. A common cause of this condition is medication. Some examples include dopamine and levodopa. In some cases, low levels of prolactin may be a sign of a pituitary disorder, for example, hypopituitarism. This is a rare condition that can delay growth and puberty in children, and cause premature aging in adults. 6. Melanocyte-stimulating hormone, MSH. It may be secreted by the pars intermedia during fetal development, early childhood, pregnancy, or certain diseases. It stimulates melanocytes to produce melanin. 7. Growth hormone, GH, or somatotropin or somatotropic hormone. Chemically it is a peptide hormone. It is a small protein with a molecular mass of 22,005, composed of 191 amino acids. It is expressed from the anterior lobe of the pituitary, produced by somatotroph cells of the anterior pituitary. It is essential for normal development, promotes growth, especially in children, and at puberty stimulates cell growth and replication through the release of somatomedin or insulin-like growth factors, IGF. Synthesis and release of GH. The synthesis and release of GH are under the control of the hypothalamic hormones. The hypothalamus produces a pair of hormones, growth hormone releasing hormone, GRH, and growth hormone inhibitory hormone, GIH or somatostatin. Both act on the anterior pituitary to stimulate or inhibit the production of growth hormone. GH is secreted by acidophil cells called somatotropes that constitute about 50% of the anterior pituitary. Under normal conditions, GH is secreted episodically at 2-hour intervals. These surges can be influenced by other physiological stimuli. A fall in circulating levels of energy substrates, free fatty acids or glucose, and an increase in protein or amino acid levels can stimulate GH secretion. Exercise or certain stresses, fever, trauma, or surgery, also stimulate GH release. Secretion is pulsatile mainly during the night. A peak in GH secretion is seen 1 hour after the onset of deep sleep. These pulses of secretion are more frequent in pubertal adolescents, facilitated by the pubertal increase in androgen secretion. Secretion of GH requires the presence of normal plasma levels of thyroid hormone. It circulates in plasma as free as well as bound with a protein called GH-binding protein. During the 6th decade, secretion diminishes considerably in both men and women. Regulation of the release of growth hormone. The regulation of the axis is by IGF-1, which acts on the hypothalamus to inhibit GRH and stimulate somatostatin. It circulates in the blood tightly bound to a large protein. It has a half-life of 6 to 20 minutes. Plasma IGF-I serves as a reflection of 24-hour GH secretion. The levels of GH rise early in sleep, in adults as well as children. Figure 23.10 Regulation of the release of growth hormone, IGF-BP1, insulin-like growth factors binding protein 1. Mode of action of GH. Its receptors are found on the cell membrane of the target tissue. These receptors are most abundant in the liver and cartilage. It acts through a second messenger as other protein and peptide hormones. The effect of GH on the liver is to produce many somatomedin or growth factors, now usually called insulin-like growth factors, IGFs. The actions of GH are mediated mainly through IGF-1, the effects of which are to stimulate growth in bone, protein synthesis in muscle and lipolysis in fat. GH also has direct actions on fat cells in liver and muscle which are not growth promoting. It causes the breakdown of both fat and muscle, the resulting glucose produced by gluconeogenesis bringing about a rise in plasma glucose. Overall, the effect of GH on metabolism is to increase the energy substrates, glucose, and free fatty acids, while stimulating protein synthesis in muscle. In fact, these effects are sometimes referred to as anti-insulin or diabetogenic effects. Following are the main actions of GH. 1. On carbohydrate metabolism, the effect of GH on increasing serum glucose levels is twofold. Glucose uptake by muscle and adipocytes is decreased while glucose synthesis, gluconeogenesis, by the liver is stimulated. Along with hyperglycemia, glucosuria, and a diabetic-like tolerance curve are also produced. It also potentiates the hyperglycemic effects of glucagon and epinephrine. 2. On protein metabolism, growth hormone is a protein anabolic hormone and produces a positive nitrogen balance. There is a fall in the blood urea nitrogen and amino acid levels. The synthesis of collagen is particularly increased. The antibody formation is also enhanced as a result body's ability to resist infection. 3. On lipid metabolism, GH decreases body fat by increasing lipolysis in adipose tissue leading to decreased fat storage. The result is decreased fat storage and an increase in lean body mass. It increases the metabolic rate and decreases the plasma cholesterol level. There is an increased tendency of ketone bodies formation because of increased plasma-free fatty acid levels. 4. On mineral metabolism, it causes the retention of calcium, sodium, potassium, and phosphate in the body. 5. Effect on the tissues. In most tissues, the effect of GH is not direct, i.e., GH must stimulate the production of another factor that mediates the physiological effects of GH. The mediators of Gh action are called insulin-like growth factors, IGF, or somatomedin. These factors, which are produced by the liver in response to GH, can act on multiple tissues to regulate their growth and/or function. It controls the somatic growth of the body as it stimulates linear bone growth primarily by increasing amino acid uptake and protein synthesis in chondrocytes, bone cells. GH causes an increase in organ size and function. 3.7.2 Disorders of the anterior pituitary gland. These are due to excess and deficiency of GH. The most common cause of excess is a pituitary tumor. In adults whose long bones can no longer be extended, the condition is known as acromegaly. In children who are still growing, excess GH causes gigantism. 1. Acromegaly, an excessive production of growth hormone in adults results in the enlargement of skeletal extremities. Growth hormone can also stimulate the growth of connective tissue such as ligaments, capsules, and synovial membranes. A combination of connective tissue growth and hypertrophied bones compresses the local nerves, causing pain, burning sensation in the joints, stiffness in the limbs, and tingling and numbness in the hands. Another condition commonly associated with acromegaly is diabetes mellitus. It affects, to some extent, up to 25% of people with acromegaly because growth hormone causes tissue resistance to insulin. Important features of acromegaly are bones and soft tissues of the hands, feet, face, acromegalic faces, and lower jaw, prognathism, become enlarged. Patients show a variety of skeletal deformities like kyphosis, hunched back, lordosis and compressed vertebrae. Coarse, oily, and thickened skin with hypertrichosis, more hairs. Excessive sweating and bad body odor. Small outgrowths of skin tissue, skin tags. Easy fatigue and muscle weakness. Cardiovascular disorders like cardiomyopathy, hypertension and congestive heart failure. There is a generalized enlargement of viscera called splanknomegaly. Visual disturbances such as bitemporal hemianopia due to compression of optic chiasma by the enlarged pituitary gland. The condition of acromegaly is diagnosed by performing two key blood tests, a test to check the level of the insulin-like growth factor 1, IGF-1, and an oral glucose tolerance test, OGTT. It is not confirmed only by checking the level of growth hormone, GH, in the body because the level varies so much in one day, even in someone without acromegaly. Figure 23.11 Acromegaly, source, rmi.edu.pk. 2. Gigantism. Gigantism is a serious condition that is nearly always caused by an adenoma, a tumor of the pituitary gland. Gigantism occurs in patients who had excessive growth hormone in childhood. The pituitary tumor cells secrete too much growth hormone, GH, leading to many changes in the body. In gigantism, growth is gradual but continuous and consistent. The affected person, with bones in normal proportion, may attain a height of 8 feet. Muscles may be well developed but later undergo some atrophy and weakening. Manifestations of gigantism include the following. Tall stature, height may reach up to 8 to 9 feet. Mild to moderate obesity, common. Macrocephaly, may precede linear growth. Soft tissue hypertrophy. Exaggerated growth of the hands and feet, with thick fingers and toes. Coarse facial features and frontal bossing. Prognathism. Excessive sweating. Severe or recurrent headaches. Weakness and lethargy. Hyperglycemia and glucosuria. Insomnia and other sleep disorders. Delayed puberty in both boys and girls. Irregular menstrual periods in girls. Deafness. The difference between acromegaly and gigantism is that acromegaly occurs in adults, typically between the ages of 30 and 50 years. Overall, acromegaly is a rare condition. The lifespan of pituitary giants is shorter than normal because of their greater susceptibility to infection and metabolic disorders. 3. Pan-Hypopituitarism. It is a condition of inadequate or absent production of the anterior pituitary hormones. It is frequently the result of other problems that affect the pituitary gland and either reduce or destroy its function or interfere with hypothalamic secretion of the varying pituitary-releasing hormones. It has the following two types. I. Prepubertal Pan-Hypopituitarism, Lorraine-Levy type of infantilism. It is the type of childhood dwarfism in which bone length is reduced. There is subnormal sexual development, example micropenis, and high-pitched voice in boys. A patient has relatively more body fat but looks older than their actual age, progeria. Skin is pale with wrinkles. Intelligence is not affected. 2. Post-pubertal Pan-Hypopituitarism, Simon disease. It is a type of pan-hypopituitarism that occurs after puberty. It is characterized by progressive emaciation, atrophy of the gonads, amenorrhea in females and impotence in males, thyroid and adrenal cortex, and loss of body hair, and those result from atrophy or destruction of the anterior lobe of the pituitary gland. There is a low metabolic rate, anemia, hypoglycemia, mental retardation, muscular weakness, and coma in severe cases which may lead to death. A special type is Sheehan's syndrome, which is caused solely by blood loss during and after childbirth. It is characterized by failure of lactation in affected women due to stoppage of lactation. 4. Pituitary dwarfism. Most instances of pituitary dwarfism result from generalized deficiency of anterior pituitary secretion, Pan-Hypopituitarism, during childhood. This disorder has the following characteristics. All the physical parts of the body develop in appropriate proportion. The rate of development is greatly decreased. Does not develop adult sexual functions. Another type of pituitary dwarfism, but not from Gh deficiency, is seen in the African pygmy and the Levi-Lorraine dwarfism. In these types, the rate of growth hormone secretion is normal or high, but there is a hereditary inability to form somatomedin C. Exercise questions. MCQ 1. A 37-year-old woman presented with complaints of anxiety, irritability, disturbed sleep and nervousness. Lab investigation and physical examination of the patient revealed that these symptoms are due to thyroid hormone imbalance. Which of the following is the chemical nature of hormone that is imbalanced in this patient? Amino acid derived. Fatty acid derivatives. Nucleic acid derivatives. Protein. Steroid. MCQ 2. A 10-year-old boy is presented with growth failure and developmental abnormalities. His hormonal assay revealed altered levels of TSH, MSH, CRH, ACTH, FSH, and LH. Which of the following is the mechanism of action of all the investigated hormones in this patient? Acting through cGMP. Acting through inositol 1,4,5-triphosphate, IP3. Acting through protein kinase cascade. Inhibiting CAMP formation. Stimulating CAMP formation. MCQ 3. A 42-year-old man is brought to the emergency department of a hospital in an unconscious state. History and examination revealed loss of large amounts of blood and vomiting due to esophageal varices. Which of the following hormones can be used to stop bleeding in this patient? ADH. Growth hormone. Oxytocin. FSH. TSH. Please write answers in the comments. End of Part 1 of 4 of Chapter 23. Thank you.